Thank you very much. I'm pleased to be here and be able to share with you some thoughts about what I've called foundations, windows, and doors, and I'll tell you in 2 slides why I called the talk that. But an overview of my experience with patient-reported outcomes in musculoskeletal disorders in particular. So patient-reported outcomes you'll hear a lot more of them in the coming years. They capture what are sometimes the most salient parts of the outcomes in research in musculoskeletal disorders, and I think in many other disorders. That's where we can capture things like function, quality of life, self-efficacy, and it's a different view than we get from clinical measures that we use in the clinic. But it's challenging. Matt Liang said in '87, function, like love, is a many splendid thing, and very much in the eye of the beholder. So there will be differences between patients, and we've seen differences within patients over time as they adapt to an ongoing chronic disease. But although it's challenging, it behooves us to measure it well. Now, if you know my life in Toronto, you'll know that, which many of you don't, but I'm actually in the middle of renovations of my house for several years. I've been doing this. So I think very much structurally. So I could think of no better way of framing a talk than talk about foundations, windows, and doors. So foundations, what's providing the foundation for our patient-reported outcomes and the way we're doing it? How strong is our foundation? What are our current windows? What's the view that we're using now to look at outcomes? And what doors are opening up to lead us into the future? Where is the cutting edge areas in the future? And these are my thoughts. So foundations, on what have we built our house of outcome measurement? We know that we're standing on the shoulders of many giants. And just who are those people? Well, I think that some of our foundations come from over half a century of tool development. This is a nice timeline that Colleen McCorney published in 2003, and it walks you through just the development of different health status indicators or patient-reported outcomes. The upper bar is showing you for generic measures like the SF-36 or the sickness impact profile that can be used theoretically across many disease groups. And the bottom one is showing that, the upper bar is stretching from 1970 into the end of the 1990s. And the bottom bar reaches way back to 1948 with some of the cancer measures or some of the very early arthritis measures where patients' opinions were sought in that area. And then it continues to grow, and I hope you can appreciate that over here in the 1990s we're seeing an exponential growth in the number of tools available, which is a bit of a caution because what you'll find is that when it says a shoulder scale, in 1995 there was actually over 17 different shoulder scales for patient-reported outcomes. So one little flag for you is that you might not have to develop a new scale, which is a very long, enduring process, but really look to see if there's another scale out there that might meet your needs because we have a good foundation of available measures. Another part of our foundation, I think, is that we have 2 decades where a lot of measurement theory has come into the health area. We've had it before in education and psychology, but we're learning how to apply that in health. So we see more measurement properties coming out and standards for the development of different tools. There's a literature on the theory of measurement, the required properties, how to do a quality appraisal. Just this year, there was the Cosman criteria that were published, which was a Delphi process trying to get people to agree on what would be a good study of reliability or of validity. The FDA in the United States also this year published their guidance statement on patient-reported outcomes. So in order to make a claim about quality of life in a drug trial or device trial, you have to have an instrument that meets their guidelines. And in terms of cross-cultural adaptation in our current world, we're doing studies across many different cultures. And those adaptation processes are now standardized. And although they might be slightly different across different groups, there's certainly an underlying trend that you could follow for how to make a tool work well in a different cultural group or a different language. The other foundation is what I consider is the theoretical framework. So work that has gone into thinking through concepts and their definition and showing us how they maybe should relate to each other in some sort of a conceptual framework. In 2001, we saw the endorsement of the International Classification of Functioning, one such framework, by the World Health Organization and then by many different research groups. And that provides us a template for how we might evaluate outcomes and what factors might affect that. And now we're really starting to see people testing that framework. So Badley in 2008 published a lovely paper trying to get conceptual clarity on certain parts of the ICF. Now this is the ICF, the main conceptual framework for the ICF. And in the middle pathway, you see here impairments, our symptoms, our pain measures, activity limitations, within the skin difficulties that people have with different tasks, and then participation restriction over here where we're talking more about role functioning. And the benefit of the ICF or frameworks like it is that they actually take environment and personal factors into effect. So if we look at Jette's example, he had in 2003 published a paper looking at outcomes relating to the ICF. He had OA of the knee and was looking at exercise benefits. And the largest effect, the biggest effect of exercise was indeed on impairment, strength, and perhaps on pain. There was some effect on activity limitations, but not as much as on impairment. That's okay. We can understand that. That makes sense. And then some effect, but smaller still, on participation restrictions. But when you have it in a model like this, you can start to make sense of that. And that makes sense because the main effect of exercise might be on strength. And maybe there's something else that's limiting the person's ability to apply that strength directly to activity limitations. So maybe they have a whole bunch of stairs they have to go up. And if we had to put stair railings in there, an environmental factor, then the activity limitations could have corresponded to the strength that they gained. But maybe there's just a bit of a barrier there. Or maybe they didn't have the confidence to take that strength gain into their workplace and improve their participation. So you can see how the models help us think through things like that. There's several models out there, and as I say, the ICF is one of the most commonly used. So the second thing I wanted to talk to you about is the windows. And I use the metaphor of windows talking about outcomes because really any outcome that you pick up is like a window. The window defines what part of the outside world we will see with that outcome measure or that instrument. And that instrument can only give you that view. It's not capable of giving you another view because it only has that view within its scope. And sometimes around the edges of its view, it's a little bit hazy because you're sort of just squeaking a peek around the edge of your window. So when you think about that, in certain circumstances, you need to go to the other side of the house and look out another window entirely to get the outcome you need. So it's not to say that one's better or worse than another. It's just they each can only give you a certain view. But the other part of the metaphor is when you think about looking out of a window, is it a clear view? Are you getting a clear, precise, accurate view every time you look out that window? Or is it foggy and gray, maybe frosted, and hard to look through? And that speaks to some of the measurement properties. So then I thought, well, what are our current windows? What's informing rehab things of best practice? And when we look at best practices, they're often hopefully based on evidence-based guidelines, which are based on systematic reviews of the literature. So let's go backwards. What's guiding our guidelines? Well, the outcomes that were put in the trials that go into the systematic reviews, that go into the guidelines to inform best practices is where we have to look. So I had a summer student, and we pulled out 24 systematic reviews from Cochrane and from Pedro of non-pharmacological management of randomized controlled trials. And there were 200 clinical trials represented in those reviews. And what we did was we pulled the outcomes out of that to say what's informing our guidelines in rehab. And this is what we found. So here's the 200 clinical trials and the proportion of them that had a measure of impairment, symptoms, function, disease or joint-specific quality of life, and quality of life generally. So there you're seeing your pain, range, joint activity, fatigue, disease like WOMAX, health status, HACS, or the SF36 EQ5D over in generic. But I hope what you take away from that is the vast majority of our current evidence-based guidelines, if they're based on clinical trials, is likely going to be based on impairment. And this right-hand side, when I sort of say lean to the right, is sort of saying we don't have as many pieces of information in our randomized controlled trials that are coming from quality of life, sense of recovery, those types of measures over here. And when we did measure those things, so clearly in impairments, a lot of us agreed that we would use a visual analog scale to measure pain. But when we got into function, there were 83 studies that measured some form of function. But there were many, many different functional measures at the disease level. So 29 different measures being used in those studies. The HAC was by far the most commonly used in 46% of the studies, but there were 3 versions of the HAC that were being used. The AIMS in 10%, a global index in 6%, and then all the other studies had one different measure in each study. So that means that when we get to our systematic reviews, the last line will say heterogeneity of outcomes. We can't do any sort of synthesis across these trials. So 2 lessons to consider. Maybe we should think about leaning to the right a bit over towards participation restrictions, broader outcomes, and make sure we're hearing that voice in our clinical trials. But also should consider whether or not we start defining a core set of outcomes so that we're consistent in how we measure and what we measure in our trials. So how clear a view are we getting? That second part of the metaphor. So the quality of measures in general, I think, are improving. There's standards being set, and I've mentioned before the Cosman results and the FDA guidelines that I commend to you And they're really setting the stage for how we should be looking at these different attributes of validity, reliability, and responsiveness. There's increasing recognition that these attributes are very context specific. So what you see as a study of validity for a certain outcome measure in a chronic disease group might not hold when you move it into an acute disease group. Or it might be done in one form of arthritis and it might not hold in another form of arthritis. So you really have to be convinced that the evidence on the table is applicable to your client group. And then the final challenge for these measures is always around interpretability. And I'm one of the supporters of the DASH outcome, and by far that's the #1 question that we get of the many hits we get on our website is, what does a score of X mean? And what does a change score of such and such mean? So let me tell you a little bit about that. Interpretability is usually when we're getting towards making some sort of a claim that the person responded to our treatment. And some people focus on change thresholds, and that's where you see minimally clinically important difference, minimal detectable difference, minimal important difference. So there's a lot of different acronyms associated with this change. And it might be things as simple as a half standard deviation. Maybe it's a bit too simple. Or an anchor-based approach where they really thoughtfully went into trying to make sure that everybody in that group had improved and what change scores associated with that. But the focus in all of this is around an amount of change. So a bigger amount of change implies that the person has gotten better. Other groups have started to shift and say, well, is it really about change? Do I care that the person's changed 10 points? Or am I really interested whether their pain's below 2 out of 10? So when people are at 2 or 3 out of 10, by and large, they start to say, I can manage with my pain at that level. I can cope with it. So is that what we want to aim for in our outcomes? Because a change score may or may not relate to a final state of 2 out of 10. And then finally, there's combinations. And I think one of the best people in this area was Jacobson in clinical psychology, who argued that if you're treating a case of depression, for example, then you want to see that your treatment has induced a treatment effect, that they've had a change in their level of depression, but you're not going to claim response until they're not depressed. So you're going to continue until the final state makes sense. So he advocated a combination of change and final state when we're trying to define treatment response. So you can see there's a lot. This is still you'll see a lot written about it in the literature. And this is where I give my geek alert. So we have these beanie caps that we put on in our research group where we're really getting a little bit too geeky with our measurement stuff. But do we really care about all these different ways of doing it? And I would say, yes, we should care if it means that the same person's being called recovered in one study and not responding to treatment in another study. So if the method makes that much of a difference, then we should be very concerned, because then the claims we're making are very different. So let's see. Here's a graph showing the proportion of people, same patients, that would be called a good outcome, depending on which criteria we use for defining that important change. Okay, so here I can say that up to 89% of my sample responded to my treatment, or I could say as low as 39% of my sample. So clearly a difference of 39 to 89 is not tolerable in clinical care. So something's happening with the methodology that we're using behind that. And that's why we need to look very carefully at how we're doing it. So pushing it further, even when we look at did they agree on who they called better or not better, the kappas, which is an indicator of agreement, were 0.4, which is not very good at all, certainly not acceptable for clinical care. And which is best? Well, we're trying to shift this over to diagnostic testing type of thing. So you'd want to see something that's very specific, very sensitive, and therefore very accurate. So we have another indicator of a gold standard. We said if patients said that they're improved and all their treatment goals were met, and the clinicians that were treating them said that they had improved and the treatment goals were met, which of these indicators was the best one at detecting that those people had all agreed that the patient was better? And in fact, we found that the final state and that combination one were the most sensitive and specific. So they seem to be the strongest against that. Now we have to try several different indicators. That's not the end. That's just the beginning of that line of research. So now let's think about doorways. Doorways are things that lead us to new places. Thresholds